Good morning, everyone. Welcome to the latest episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is a deeper dive into the 2024 Medicare Physician Fee Schedule Final Rule. PYA is happy to present today's webinar. You may submit questions during the webinar by typing a message into the questions pane of the control panel. Also, immediately following the end of the webinar, you will be asked to complete a short survey and submit any additional questions. We will respond to questions posed after the webinar via email. We have posted in the handouts pane of the control panel a PDF copy of the slides for your reference. Also, you will receive an email later today with a copy of the slides and a recording of this webinar. With that, I would like to introduce our presenters, Valerie Rock, Carine Leslie, Katie Croswell, and Miriam Murray.
Thank you, Caitlin. Thank you all for joining us today. We appreciate you tuning in to another episode of the Healthcare Regulatory Roundup as we walk into the 24 fee schedule and walk you through all of these changes, taking a little bit of a deeper dive than Kathy and Marty did in the last episode. If you heard that, you heard the top 10 of what kind of key updates related to the 24 fee schedule, but we're going to take a deeper dive, as the title alludes to, into some of these elements that will help you apply and determine how to comply with these services and changes that are occurring. So I want to welcome the team that's joining me today. Again, my name is Valerie Rock, and I'm joined by Carine Leslie, Miriam Murray, and Katie Croswell, where we serve as the part of the management team over the revenue integrity services and regulatory compliance services that we provide, and bring to you today about 80 years of experience that we can use to interpret these requirements and share with you how we think that things might go in the next year. So we're going to jump right into these concepts. Again, we're going to hit these pretty hard and deep. And so as you're listening to this today, you may want to listen to this again in the future. We will have the recording out on our website after this. So take notes today and think through how you'll apply these. And then as you interpret these and as you walk through this and as you get additional guidance from Medicare, that will help you further refine how you will be applying these requirements. So we'll start with the conversion factor because it is so important to understand what is shifting and how it's shifting. What you'll see here is that we have a negative 3% roughly decrease in the conversion factor. That means that all of the codes are being decreased in value from a reimbursement perspective by 3%. This is predominantly related to the implementation of the G2211. So we're going to talk about that in detail. What this is going to do is cause the physicians that are doing surgical services and the proceduralists and surgeons basically are going to get a decrease in revenue as they are working through 2024. And those that are providing primary care services or those that are able to bill that G2211 will see an increase in revenue and an increase in work RVUs. So we'll talk about that. The only possible way that anything is going to change or mitigate this downturn or decrease or adjustment to this conversion factor is if Congress acts. There is an appropriations bill on the floor that may be signed January 19th that may mitigate this downturn, but if not, and there may not be the political will to do it, then we will see this adjustment. Again, this G2211 will mitigate some of that risk if you're able to bill for it. Otherwise, you will see that downturn. Another thing that might happen in the future is a change to align the conversion factor with the Medicare Economic Index. If that occurs, then we'll see a slight adjustment up every year, which will be more in line with what we see from an inflationary standpoint. And that's the goal, I think, in the future, but we're not there yet. So what is this G2211? Well, it's been around technically since 2021 when it was originally released, but there was a moratorium placed because of COVID to not implement it until 2024. So here we are, instead of a bundled code, it is now active within the fee schedule effective January 1, 2024. The definition of this code is visit complexity inherent to evaluation and management, which is E&M services, associated with medical care services that serve as the continual focal point for all needed healthcare services, and or with medical care services that are part of an ongoing care related to a patient's single, serious, or complex condition. So focusing on, I'm a provider that's the focal point of all of the care of the patient, or I'm a provider that's managing the longitudinal care of a serious, single, or complex condition. The idea is that CMS believed that in 2021, when the work RVUs were increased for the office codes, when the office codes were changed, the guidelines were changed in 2021 for these office codes, that the resources associated with taking care of a patient longitudinally and being the focal point of that care were not being appropriately reimbursed. So then they decided to include this code to increase the value of that service, or really reimburse for that service. So instead of going back to the drawing board for determining an increase in valuation for the work RVUs, they applied this separate resource code, which is technically an administrative burden. So we anticipate some initial pushback on the utilization of this code, and maybe they have to go back to the drawing board on this code, but for now, we'll use it when appropriate. So when is it appropriate to use this code? When you're billing an office or outpatient code, you would use this code as an add-on code, meaning in addition to the office code, so the 99202 through 99215, you would bill the G2211 on the same claim if this patient is Medicare or Medicare Advantage, because Medicare Advantage has to provide minimally the services and benefits that are provided by Medicare. New or established office or outpatient E&M services. When the patient is having an E&M and psychotherapy on the same day, you can use this code. And again, when the provider is taking responsibility for the ongoing subsequent medical care for the patient and has a longitudinal care relationship with the patient. But it would not be billed by any of your commercial payers, Medicaid, anyone that's in a capitated payment model, unless they state specifically that they're going to allow the code. It's not likely that they're going to throw money at you and have you add this code. So G codes are utilized by Medicare to allow for reimbursement that does not align with CPT. So at this point, this is a Medicare code only. When you're billing an E&M with 24 or 25, or on the claim you include a 53 modifier for reduced service or discontinued service, then you would not bill this code. So if you're performing an E&M code along with an injection and you're billing a 25 modifier on that E&M, you would not be able to bill this code. So keep that in mind for a proceduralist that you're thinking about utilizing this code for. If they have a high number of 25 modifiers within their data set, it's not likely to be administratively reasonable to utilize this code, but you can weigh out the benefits and administrative burden on that. Any specialists that are predominantly proceduralists and they're not managing the patient for the longitudinal care, so they're just there for a surgery and then they go back to their primary provider, this would not be for that type of surgeon. I'll make a note again on that 25 modifier, the 24 modifier and 53 modifier. You may not have heard those other two modifiers, but they are included in the 2021 fact sheet that was produced initially when the code was released, and they're referenced within the final rule. So I wanted to make sure that you knew that those modifiers were also included. So what do we look from a financial perspective? Again, the budget neutrality adjustment for the utilization of this code, because originally it was considered about $3.3 billion worth of revenue associated with this code. So 90% of the budget neutrality adjustment is associated with this code. It's a 0.33 work RVU and about $16 worth of revenue. So you're going to mitigate the downturn, again, about $2 for 99213, downturn for the conversion factor, and a 16% move up for utilization of the G2211 means that you have about a net $14 increase if you're using this code. The good part about this code is that we're increasing the work RVUs and increasing reimbursement. So you have kind of a linear upward, basically linear upward adjustment of the revenue and the work RVUs. So compensation will somewhat align, increase in compensation, increase in revenue, which will be helpful. As opposed to the surgeons that are then having a decrease in revenue, but and a stabilization of their work RVUs, so profit margins will be squeezed for those surgeons. The individual impact of the code is going to vary depending on utilization, so keep that in mind. It's not going to be known in advance how this is going to impact you in total. You'll have to do studies to determine that. If you're utilizing fee schedules from a prior year for compensation, then look at the 2024 compensation, the utilization of the G2211 as you're determining utilization of a current fee schedule. The risk of utilizing this code is both from an overpayment perspective and a False Claims Act perspective, because if you're deemed as using this code in a way that is not linear or not in alignment with CMS's expectation, whoever is auditing you's expectation of this code, then you could be seen as out of bounds and receiving revenue that you weren't intended to receive. So this is a risk that you'll want to make sure that you're utilizing this code in a conservative but wise way. So the expectations originally on this code from a utilization perspective was 90% of all office and outpatient E&M codes, but it's been revised to 38% initially and 54% once it's fully implemented. But this is for all office and outpatient E&M, surgeons that utilize E&M, the primary care providers. So don't utilize these percentages as a benchmark for your practice or your providers, because that would be incorrect. We'll see over time how the utilization works and start looking for benchmarks in the future. So what's a possible strategy for you to use in order to implement this code? If you think about it from a patient perspective, if you say, okay, physician, here's your patient load. Here are all your Medicare patients. And here are the patients that you see on an annual basis for an AWV, for an annual wellness visit. And you might be providing an E&M on the same date as that AWV, but if that's applied with a 25 modifier, you wouldn't be using the G code anyway. So do you see that patient in addition to that annual wellness visit every year? Then maybe those are the patients that you would say, okay, we're going to apply the G2211 every time the patient comes in for an E&M code beyond that AWV. So that would be a safe patient to do that for if you are that primary care physician providing that AWV. Now, if you are not, then and you're more of a specialist in a certain area, but you do a lot of office-based E&M services, and you're managing one of these conditions, serious conditions for the patient longitudinally, then every time that patient comes in, then you would bill the G2211 into the, they're coming into the office, clinic visits and things like that. You would use this code. So those are the types of patients that you would want to consider that for. To the extent you can do this in an automated way, we would suggest that because you want to decrease the administrative burden on your practice to do that, but you'll want to audit and monitor to make sure it is accurately applied, whether you have your billers do it or whether you have this in an automated fashion. So split shared visits. We have a complete shift in split shared visits. So we want to orient you first into split shared visits in that they are E&M services that are provided by a physician and a non-physician practitioner on the same date of service. And the practitioners, both the physician and the NPP, are within the same group practice. This is not for non-facility settings, so this is for your hospital visits, for your SNF visits. As of 2022, this includes SNF. If the NPP has to bill, then it'd be 85% of the fee schedule, whereas if a physician bills, it's 100%. So from here, I'm going to be talking about how do you comply with these rules in order to bill for the physician or under the physician's NPI. In 2021, the split shared guidelines were stripped from the CMS manual because they no longer aligned with CPT when the CPT book now includes the E&M guidelines. So 2021 is when we got office and outpatient 2021 E&M guidelines. That shifted and included the split shared guidelines and removed history and exam from the medical, or now you only have medical decision making or time to use for the determination of a code. Now, in 2022, we were still using 95 and 97 for facility services. So in 2022, CMS came out as a finalized rule to include either time or history exam or medical decision making in total by a physician in order to bill under the physician. So time as more than 50% of the time, or history exam or medical decision making documented independently by a physician in order to support the code level and to bill that level of service. When we went to 2023, the facility update occurred for E&M guidelines. So now we don't have history or exam as quantifiable in our guidelines. So the use of history and exam and medical decision making in the 2023 determination of the substantive portion of the visit is then confusing, because all you have then is that the physician is documenting some level of history or exam potentially based on their determination of what's appropriate, and then you start to see a bifurcation of the max determining how do you actually document that? How do you determine a substantive portion of the visit? Do you have to have a face-to-face visit in order to do that? Who's signing the record and things like that? And we go in many, many different directions. Time is still allowed, but it's not likely to be utilized because typically the NPP is providing majority of that time. So how do you document this well? In effect, this is very difficult to audit. This is very difficult to implement, and we recommend asking for leniency if these codes and services are billed in or included in an audit, because it's very difficult to implement. Keep in mind that in 2023 and 2022, the critical care services are still implemented as is from 2022 based on time only. So make sure you're up to speed with those critical care requirements for split shared services. So 2024, we thought that based on the proposed rule that we would be shifting from, or basically kicking the can down the road, waiting to implement this time only concept, where time would be required in essence, in full, that you wouldn't use medical decision making or history or exam to determine the substantive portion of the visit. So we were concerned that that would create a shift completely in who would be billing for the service. But because CPT in 2024 has just released a definition for split shared visit, it's expanded, then CMS said, we're just going to align with CPT. So they said, we're going to align with CPT, and that the substantive portion of the visit, if performed by a physician, could be billed then under the physician. The MPP or physician performs the face-to-face service. More than half the time spent in time could still be utilized as substantive portion of the visit, or medical decision making. So it's time or medical decision making, just like the guidelines that we utilize today, that all we have from a quantifiable perspective is time or medical decision making. So we're going to focus on medical decision making. So what does it say actually in CPT guidance regarding that? What you'll see is for time, it states clearly here that the physician does not have to spend face-to-face time with that patient in order to count that time. It can be non-face-to-face time that is utilized by that physician to support the substantive portion of the visit. It's reiterated within the CMS final rule. So MACs should not be requiring face-to-face time in order, or face-to-face visits in order to get the substantive portion of the care. So if they are, I would recommend communicating with them. Now keep in mind that this is for CMS only, this is Medicare only. in the sense that you have a hospital bylaw or a state requirement that you have to have a face-to-face visit with that patient, that still stands, right? We're not negating anything that you are required to do from that perspective. This is just from a CMS perspective and billing these codes. Now, what you get to when we're talking about medical decision-making, you'll see the 3 elements of medical decision-making listed here in green. So we've highlighted this from the requirements. So the number and complexity of problems addressed, the risk and amount and complexity of the data are the 3 elements that we are looking for when we're auditing for medical decision-making. What this means is that, and how they're focusing this is on these first 2, the problems addressed and risk, that if the physician made or approved the management plan and takes responsibility for that plan, then they have, by doing so, a physician or QHP has performed 2 of the 3 elements used in the selection of the code level based on medical decision-making. So in essence, by approving the management plan for the problems addressed and taking responsibility for that plan, they have supported 2 of the 3 elements and thereby are allowed to bill the code, that they're billing under their own number as a physician. Now, as you shift into the data element, you'll see that CPT starts talking about the code level to support as opposed to identifying the billing provider. And so this gets a little bit complex, more complex than I think it needs to be, but read it and understand that there's certain elements that have to be personally performed by the physician in order to count them towards the code level. So that's important to note, important to understand, and important to communicate to the physician that they will need to document what they're reviewing, what they're approving, and what they're actually doing in order to account appropriately for the code level. Now, we have a sentence in the final rule that is concerning. So this is, although we continue to believe that there are instances where medical decision-making is not easily attributed to a single physician or NPP when the work is shared, we expect that whoever performs the medical decision-making and subsequently bills the visit would appropriately document the medical decision-making in the medical record to support billing of the visit. This is, if interpreted as that the physician has to document the medical decision-making in alignment with the code level in order to bill for the code under their NPI, then that is a bifurcation from the CPT requirements and an increase in requirements from those requirements, because CPT is basically saying, I reviewed and agreed and under the direction of my care that that this medical decision-making is appropriate. If you take a conservative method to apply this, then you would expect the physician to redocument the medical decision-making in order to support the level of service. But that is not really the intent of CPT. So monitor the CMS manual for updates to see how CMS communicates how to document this service. One thing I want to note is that there are MACs out there, such as CGS, that has included documentation expectations that may be a little bit more detailed in some aspects, but they also consider some lesser documentation even now, even when history and exam are required, or one of the two may be required. It states that in addition to comply with CMS's medical documentation reduction guidelines, CGS would consider the following medical record documentation by the physician adequate to support a split shared visit. I have personally seen and examined the patient independently, reviewed the NPP's history exam and medical decision-making, and agree with the assessment and plan as written, signed by the physician. So if that is allowed currently by CGS in order to account for the medical decision-making or some level of the history exam or medical decision-making, then perhaps that is all that would be necessary to document, in this case, for medical decision-making and taking over the care of that patient. So keep that in mind as you're trying to implement this, because we don't want to go off the rails and then increase the documentation requirements when it's unnecessary. So monitor your MAC recommendations as well. So in the CMS manual, there are specific medical record documentation requirements, including identifying the physician and NPP who performed the visit. Whoever does the substantive portion of the visit has to sign and date the record. The physician does not have to have face-to-face contact with the patient in order to bill the service, but you do have to use the FS modifier, whether the NPP or the physician is actually billing for the service if the service is split shared. So keep all of this in mind as you're implementing this, and again, monitor these updates for the CMS manual. So we're not expecting the change that we thought would occur if time only was what was implemented. We anticipate the utilization to be about the same as historically it has been, so we don't anticipate this also impacting compensation models. That should alleviate our fears going forward with this code, but manage and monitor the way this documentation is occurring. We continue to see a lack of documentation from physicians in order to support split shared services. So getting the documentation in there, even this minimal documentation that I'm describing, will be key to really supporting these split shared services. So with that, I'm going to turn it over to Carine to talk through telehealth.
Thanks, Valerie. So to kick off for telehealth, I think the one thing that's good to say, and the great thing that has come out of the final rule, is that it's clear that we're not immediately transferring or shifting back to our 2019 pre-COVID, where we have to have in-person visits. We've been able to show and build the case for telehealth services more broadly during the pandemic. And so while there are continued extensions to the services that can be performed via telehealth, one of the factors and one of the things that was interesting that was stated in the final rule is that CMS is to act as an appropriate safeguard to ensure that beneficiaries receive all of the elements and benefits of services when that service is furnished via telehealth rather than in person. And so assessing the clinical benefits of the services furnished via telehealth long-term and carefully study over the period of years may be necessary. So what CMS has essentially indicated is while they're continuing to push forward the telehealth requirements through 2024, data and feedback from the community, from various organizations will continue to be gathered. And as we start to operate under more normal conditions, right, in 2023 and 2024. And so they'll continue to identify what services are safe and what services are effective for patients on a go-forward basis. So when we talk about telehealth and what has changed in the final rule, one of the changes that has occurred is that they've, instead of the three categories are previously indicated, categories 1, 2, and 3, what they've essentially created is a permanent and a provisional list. And so these two, provisional and permanent lists, are replaced in the categories 1 through 3. And so when there's a recommendation from the community to add a particular service, they are, instead of categorizing them as 1, 2, or 3, or they're categorizing them as permanent versus provisional. And so what's interesting is that though the final rule is not changing significantly for what was proposed and what is in 2023, it's important to understand kind of what's continuing forward and what's adjusting as such. And so the final rule has various policies that were finalized in 2023. There are some minor changes, but there's going to be continued extensions. For example, the 151-day extension period that was discussed in the 2023 final rule is going to be extended through December 31st of 2024. And so they're going to delay the requirements for an in-person visit when that physician or practitioner hasn't seen the patient within 6 months for the mental health and telehealth services. And then the subsequent interval and similar requirements for rural health clinics and federally qualified healthcare clinics. All of those requirements, that 6-month requirement, the need to see the patient for mental health services, those as of right now will not be a requirement, but will go into effect on January 1st of 2025. In addition to that, they've added a few providers that can see patients within via telehealth, and that is a marriage and family therapist and then mental health counselors. And so as organizations that provide behavioral health services know that those providers are now being added as practitioners for distance site purposes. Through the calendar year 2024, distance site practitioners will continue to use their currently enrolled practice location. And so there was an anticipation that if a provider was at home providing telehealth services, then they would need to use their home address on the claim. And the concern, which is a valid concern that was posed by several commenters, is that in the environment that we are in, there's a risk of providing the provider's home address and things that have occurred. And so CMS has agreed to continue to allow the provider to use the location of their practice where they would provide the service, whether they are, even if they are at home providing telehealth services. They've also extended the flexibilities for temporary expansion of telehealth services. And so the interesting thing is now that patients can take services at home, they've extended to include the patient's home as a distance site location. And that home does not necessarily need to be the patient's actual home, because we understand that everyone has a different situation. And so that includes temporary housing, so hotels, a homeless shelter if a patient is traveling and they are in a hotel. What they are considering their home is going to be important from a documentation perspective, but CMS is including all of those. From a billing perspective, though, for billing for these telehealth services, providers will no longer need to submit modifier 95 along with a place of service where the service would have occurred. So if it's in the office, in their clinic setting, so place of service 11, what the provider will use instead is either place of service 2, indicating that the telehealth provider is providing the service, is a service that's being provided other than in the patient's home, or place of service 10, indicating that the service is being provided within the patient's home. We know that in 2023, CMS was not reimbursing and providing reimbursement for the use of place of service 10, and so providers were utilizing place of service 2. While that has changed, place of service 2 will continue to be reimbursed on as the facility rate. The place of service 10 will now be reimbursed at the non-facility rate per the physician fee schedule. While that is impactful and important from a clinic perspective, so in the office setting and other outpatient settings, billing for payment though in the telehealth services when the clinician is in the hospital. So for example, a physician seeing a patient, the physician's located within the hospital walls, and that physician is seeing another patient within that hospital via telehealth or within another hospital via telehealth. There's a difference in how to report those services. You would not utilize the place of service of 2, you would actually utilize the place of service of the hospital. So the clinician that is in the hospital and the patient that is at home, the billing provider would use the place of service of the hospital and they would append the modifier 985 to that claim. And so while for other services within the clinic, you use the place of service of 2, or if the patient's at home, the place of service of 10, the provider would continue to use the place of service of the hospital when they are in the hospital and the patient's at home. And that is applicable for hospital services and other outpatient therapy services as well. Next slide, please. Next slide, please. So while therapy services by PT, OT, SLP providers and services for diabetes self-management training and medical nutrition services are going to continue to be reimbursed, there is some uncertainty as whether those, the extension of those services being reimbursed by the institutional staff will extend beyond 2024. So just know, as I said at the top of this section, is CMS is going to monitor the continued use and the importance and the clinical benefits of telehealth services. And so for those PT, OT, and SLP services that are provided by telehealth, it's important to continue to document appropriately and continue to support the benefits for the patients from a patient perspective. Next slide, please. So how do you document for telehealth services, right? You want to make sure that you're communicating within your documentation what's occurring, where the patient's located, where the provider is located. So from an E&M perspective, the typical documentation would be important as if the patient was being seen in person, so history, exam, and medical decision making. But from a documentation for telehealth services, you want to be able to document what platform was utilized. Was it an audio only service, or was it audio visual? Because the reimbursement for that and the types of services that are billed are different. Where was the provider located? Where was the patient located? Was the provider in the hospital and the patient at home? And then the names of the individuals that participated in the care. So if there are other providers, such as an NPP or a nurse or a therapist or anyone of that sort, what was their involvement in that patient's care? Because you want your documentation from a whole, from an organization perspective, to be able to support everything that's being billed, and then that helps support the place of service that's being billed as well. And so supporting that place of service of 10 and supporting the place of service of 2 can be seen very well within the documentation, as long as those elements are included as they need to be. Thank you. So let's jump into virtual supervision. It's a hot topic, and I think providers have been able to create a world in where virtual supervision is working for them and being able to provide care in a manner that supports supports the clinical benefit of that. So prior to the PHE, direct supervision required the immediate availability of the supervising physician or other practitioner, even though that provider did not need to be present in the same room for the service that was being performed, but they needed to be immediately available. So that requirement meant that the provider had to be in person physically in the office suite for when a service was being provided. And so the virtual option was not an available option. But of course, the PHE changes everything, right? So at the start of the PHE, the definition of direct supervision was changed to what we know as virtual supervision today. So which allowed the supervising provider to be immediately available via a two-way real-time audio video technology instead of requiring the provider's physical presence. So for example, a patient is receiving infusion services in the infusion suite, the provider needed to be available, whether that's by an iPad or video conferencing, some other tool. They needed to be available in case something occurred with the patient. We know that there were several comments that were submitted during the proposed rule and continuing to keep the virtual supervision requirements. It's good that it's continuing through 2024. But it is noted within the final rule that Medicare is recommending that organizations, practices, plan to reorganize the procedures that they've had in place for the past 3 years, so that they continue to form an action plan to return back to the pre-PHE direct supervision requirements without the use of that audiovisual technology. Since there's the consideration that we would revert back to the pre-PHE requirements. Though that's stated within the final rule, and it's important to implement that and consider that as you're planning for 2024 and how that impacts your practice, your organization in that way. Know that CMS is continuing to gather data. They're still considering what services can be provided and utilized, even though the direct supervision is required, how direct supervision can still be utilized for patients for certain services. Some of those services are those that are mostly performed by auxiliary personnel, such as maybe an IM injection or level 1 E&M visits for established patients or level 1 ED services. Those are considerations that CMS has stated within the final rule that virtual supervision may continue past 2024. But from a planning perspective, consider creating a plan for your organization to see how the impact of removing a virtual supervision will impact you through 2025. Next slide, please. And so in that same communication and same information, teaching physician services will continue to have a virtual presence as well in all settings. While there's a difference in how that looks in 2024, clinicians will need to they'll need, from a teaching service perspective, clinicians will have to provide virtual services, for example, in a 3-way telehealth. So there'd have to be video audio for the patient, video audio for the resident, and video audio for the teaching physician. The teaching physician would need to have some type of virtual presence during the key portions of the virtual service for which payment is necessary for. So for example, in order to bill for an E&M service, the physician would need to be present, virtually present through from an audiovisual perspective for the medical decision-making component. And so for all training sessions, for all residency programs through the end of 2024, they'll still allow that telehealth perspective. The virtual presence would require some real-time observation of the teaching physician, not just the provider's availability. So they would actually have to be on video when the resident is seeing the patient or assessing the patient. And it does exclude audio-only technology. So the teaching physician cannot just be on the phone listening in on the service. They actually need to visually see what is occurring. And then the medical record documentation, it's important to note that teaching physician would need to indicate what portions that they were present for, whether that is virtually or physically present for. And so, providers document in a sense of here's what I was available for, here's what I indicated, but indicating the physical presence of that provider. So if you were in the room with the patient or you were there physically with the resident, or vice versa, the resident was there with the patient and the teaching physician was there virtually, that would need to be clearly documented within the medical record. And then again, sorry, one more notation. The last piece of information that I think is important is that though they are allowing the continued virtual presence for teaching physicians, they are not extending it to certain procedures and services that are high risk. So high risk surgical procedures, interventional and endoscopic or complex procedures. The resident or teaching provider will have to be in person for those services. And with that, I will turn it over to Miriam.
Thank you, Carine. And now let's move over to remote patient monitoring. There are a few new revisions in the 2024 final rule. The first revision is to permit therapy assistants to furnish remote therapeutic monitoring services under general supervision by their PT and OT in private practice. Under current regulations, PTAs and CODAs require direct supervision by their supervising PT and OT in private practice. However, in order to align with the 2023 supervision requirements for RTM, CMS revised the supervision for therapy assistants to general supervision for RTM services only. CMS is considering revising the current supervision requirements for therapy assistants and is soliciting comments for possible future rulemaking. For patients receiving remote monitoring services during a global period, CMS clarifies a practitioner may furnish RPM or RTM services, but not both, to a beneficiary so long as the remote monitoring services are unrelated to the diagnosis for which the global procedure is performed and are addressing an underlying condition that is not linked to the global procedure or service. Next, RPM requires an established patient relationship. The final rule clarified the RTM services similar to RPM would also be furnished to a patient after a treatment plan has been established. And then lastly, they added remote monitoring services for both RPM and RTM to rural health care management services. These are reimbursed under the GO 511, and the intent is to increase access to remote patient monitoring services to beneficiaries in these rural areas and reimburse the RHC appropriately for the additional services of RTM and RPM outside of an in-person encounter. Next slide. As we know, RPM and RTM require data collection for at least 16 days in a 30-day period. The 16-day data collection requirement does not apply to the RPM and the RTM treatment management codes. These CPT codes account for treatment time spent in a calendar month. Remote monitoring services can be billed only once during a 30-day period, even when multiple medical devices are provided to a patient, and only when reasonable and necessary. As a clarification, either RPM or RTM, only one practitioner can bill for these services during a 30-day period. RPM and RTM may not be billed together so that no time is counted twice by billing for concurrent RPM and RTM services. The intent is to allow flexibility for a provider to select the appropriate mix of care management services without creating significant issues of possible fraud, waste, and abuse associated with overbilling of these services. CMS also stated either RPM or RTM may be billed in conjunction with any one of chronic care management, transitional care management, principal care management, chronic pain management, and behavioral intervention codes, as long as all requirements to report each service are met and without time or effort being counted more than once. So no double dipping across these services. Next slide. CMS also had some positive additions to diabetes services provided to Medicare beneficiaries. With type 2 diabetes affecting more than 250,000 Americans aged 65 and older and costing billions to treat each year, Medicare implemented the Medicare Diabetes Prevention Program model to try to slow this trend by preventing or delaying type 2 diabetes for people with prediabetes. The MDPP is a year-long program to provide training and education to beneficiaries to help them manage their health. So what changed in the final rule? CMS expanded the MDPP model through 2027. The goal is to make the program more marketable to suppliers and beneficiaries and allows beneficiaries to obtain the MDPP services either in person, through distance learning, or a combination of the two for a period of 4 years. This will also allow CMS to evaluate the impact of the MDPP program and its results. Next, CMS simplified the current performance-based payment structure for MDPP by allowing fee-for-service payments for beneficiary attendance while keeping performance-based payments for beneficiary weight loss. Up to 22 sessions are furnished over 12 months by a trained coach who provides training on diabetes, health, and behavioral strategies. The primary goal of the MDPP is to help Medicare beneficiaries reduce their diabetes risk by achieving at least 5% weight loss. CMS stated that the current payment structure did not incentivize beneficiary retention. So as a result, they adjusted for fee-for-service payments for beneficiary attendance in this final rule, allowing up to 22 attendance-based payments versus the 5 that are currently in place. Next, CMS extended the option for MDPP suppliers to conduct the training and education through virtual communications. One of the issues to be addressed was alternatives to in-person weights. So MDPP suppliers can now obtain weight measurements in a couple of different ways. First, via digital technology using scales that transmit weights via wireless or cellular transmission, or self-reported weight measurements that are obtained during a telehealth visit with a coach who is going to observe the beneficiary weighing themselves and view the weight on the at-home digital scale. This flexibility allows suppliers to bill for beneficiaries achieving weight loss performance goals. CMS anticipates changes will increase the number of eligible suppliers and remove barriers for beneficiaries to attending in person. Next slide. These are a couple of additional items that CMS had in the final rule. And first is the diabetes screening test. In short, CMS is now allowing the HbA1c test to the types of diabetes screening tests covered by Medicare Part B. Expanding the coverage of diabetes screening to include the A1C test will allow measurement of different aspects of diabetes pathology compared to the already covered diabetes screening test. The A1C test will require no Part B coinsurance and deductible when furnished as a covered diabetes screening test. They also adjusted the frequency limits to no more than twice within a 12-month period, allowing following the date of the most recent diabetes screening test of the beneficiary. Adding the A1C test and expanding the frequency limitations will remove barriers, expand access, and empower clinicians to apply multiple types of tests or with increased frequency when the circumstances of the patient demonstrate a medical necessity. And then lastly, diabetes self-management training and medical nutrition therapy. CMS clarified that registered dietitians and nutrition professionals can be paid for their professional medical nutrition therapy services only when the services have been directly performed by them. Registered dietitians and nutrition professionals may also bill for diabetes self-management training services as the DSMT certified provider, regardless of which professional furnishes the actual education services. DSMT education services can be provided by RNs, pharmacists, or registered dietitians and can be billed under the RD as long as the DSMT services are under the supervision of the DSMT certified registered dietitian. Now to Katie Croswell.
Thanks, Miriam. I'm going to be going over some changes related to health-related social needs services as well as behavioral health services. We're going to start by looking at new reimbursement for services to better address the impact that social determinants of health have on patients. The first is the Social Determinants of Health Risk Assessment, SDOH. The second is Community Health Integration, or CHI. The third is Principal Illness Navigation, or PIN. And lastly, PIN peer support. So first, let's dig into the SDOH risk assessment, which is going to be billed with HCPCS code G0136. This code represents the administration of a standardized, evidence-based SDOH risk assessment tool, taking about 5 to 15 minutes and not performed more often than once every 6 months. It does not serve as a screening tool, but rather it's tied to one or known or suspected SDOH needs that may interfere with the practitioner's diagnosis or treatment of the patient. It does not need to be furnished the same day as an E&M visit, but it's generally not performed prior to a visit. It's an optional additional element of the annual wellness visit, and there is no beneficiary cost sharing when it's conducted as part of the annual wellness visit. CMS recognizes that SDOH risk assessments are an emerging and evolving tool, and so they encourage clinicians to explore the many tools available. We have listed in this slide the tools that CMS listed in the final rule, but they're not required. These services can be furnished by auxiliary personnel if incident 2 requirements are satisfied, and the service is included on the Medicare Telehealth service list. Next, we're going to move on to Community Health Integration, CHI, which is billed with HCPCS code G0019 and G0022. Prior to performing these services, there has to be an initiating visit. The initiating visit can be an E&M, a transitional care management, or an annual wellness visit, in which the billing practitioner identifies the presence of an SDOH need that limits his or her ability to diagnose or treat the problems addressed in the visit. The initiating visit cannot be provided in the ED, the inpatient or observation setting, or a SNF, as those settings would not typically provide continuing care to the patient. The initiating visit is not required every month that CHI services are billed, but only before beginning CHI services to establish the treatment plan, specify how addressing the unmet SDOH needs would help accomplish that plan, and establish the CHI services as incident 2. So G0019 is going to be billed for this first 60 minutes per calendar month, and G0022 is listed separately in addition to G0019 for each additional 30 minutes. In the next couple slides, we're going to go over what's included as part of this service. So this service can be performed by a certified or trained auxiliary personnel under general supervision of the billing practitioner. However, that person must be certified or trained to perform all included elements and authorized to perform them under state law. The service elements include a person-centered assessment, practitioner, home, and community-based care coordination, health education, building patient self-advocacy skills, healthcare access and/or health system navigation, facilitating behavioral changes as necessary for meeting diagnosis and treatment goals, and facilitating and providing social and emotional support. Next slide. Personnel must document all activities performed in addition to time, because these are time-based codes, in the billing practitioner's EHR. They must include the relationship to the SDOH need intended to address and clinical problems intended to resolve. Only one practitioner can bill for CHI services in a given month, and you must obtain written or oral patient consent following notice of cost sharing. The service cannot be billed when the patient is under a home health plan of care. It can be billed in the same month as care management services, but no double counting, and we'll talk about that a little bit later in detail. And lastly, the billing practitioner can arrange to have these services furnished through a third party. So now we're going to move on to Principal Illness Navigation, or PIN, which is billed with HCPCS code G0023 and G0024. PIN services are designed to help patients identify and connect with appropriate clinical and support resources for a serious high-risk disease that is expected to last at least 3 months and places the patient at significant risk of hospitalization, nursing home placement, acute exacerbation, decomposition, functional decline, or death. It requires development, monitoring, or revision of a disease-specific care plan and may require frequent adjustment in medication treatment regime or substantial assistance from a caregiver. G0023 is the first 60 minutes per calendar month, and G00 is each additional 30 minutes, and CMS has not set a frequency limitation on that code. Next slide. Like the CHI services, PIN requires an initiating visit, which can be an E&M, TCM, or AWV visit. And the billing practitioner needs to identify the medical necessity for these services, establish a treatment plan, and specify how PIN services will accomplish that plan. Subsequent services can be performed by certified or trained auxiliary personnel under general supervision of the billing practitioner. But like the CHI, they must be certified or trained to provide those services and authorized within the state to do so. Next slide, please. Staff conducting these visits must make sure to document all activities, including the time in the billing practitioner's EHR, include the relationship to the treatment plan, and document any identified SDOH needs. Providers must ensure PIN time and effort is not being duplicated for patients with multiple principal illnesses at one time. So for example, if a PCP is providing PIN services to a patient for one high-risk condition, and then the patient gets diagnosed with another high-risk condition that's also being managed by that PCP, the same navigator working incident to the PCP would be unable to perform the PIN service elements without duplicating time and effort. So the PCP could only provide PIN services once per month for that beneficiary. However, more than one practitioner can bill for PIN services during a given month in limited circumstances. Medicare stated that they would not expect a patient to require multiple PIN services for a prolonged period of time, except in circumstances where the patient's receiving services for highly specialized navigation, like behavioral health or oncology. Again, you must obtain oral or written consent following notice of cost sharing. And again, the billing practitioner can arrange to have a third party furnish these services. Lastly, we're going to talk about PIN peer support, which is billed with a HCPCS code G0140 and G0146. CMS believes that the work provided by peer support specialists is crucial to the treatment of some patients with behavioral health conditions, and therefore finalized 2 new codes to support that. The first is G0140, which is the first 60 minutes per calendar month, and G0146 for each additional 30 minutes with no frequency limitations. These services are furnished by peer support specialists, but limited to beneficiaries with severe mental illness or substance use disorders. It's like PIN, except it's tailored services consistent with peer support specialist scope of practice. and PIN peer support cannot be furnished concurrently for the same condition. And again, written or verbal consent is required as long as it's documented. Next slide. So I think it was worth mentioning that PIN services can be furnished in addition to other care management services like principal care management, as long as the time and effort are not being counted more than once. So on this slide, you can see the different requirements for PCM, PIN, as well as PIN peer support services. So you want to make sure that you're understanding the different requirements for each service if you do plan on billing them at the same time. So now we're going to move on to some behavioral health service changes. The first one Carine kind of touched on during telehealth, which is covered in payment for marriage and family therapists and mental health counselors. Payment for their services is going to be at 75% of the psychologist rates. And these providers can be on the list of practitioners for RHCs and FQHCs. Second, Medicare is finalizing 2 new G codes to describe psychotherapy for crisis when furnished in an applicable site of service. G0017 for the first 60 minutes and G0018 for each additional 30 minutes. It can be furnished in any non-facility place of service other than the physician office setting, and payment is set at 150% of rate for the physician office setting. The third change is allowing clinical social workers, next slide. Thank you. Permitting social workers, MFTs, and MHCs to bill for a health and behavior assessment and intervention services, and we've listed those CPT codes there. The fourth change is an increase in WRVUs for patient one-on-one timed behavioral health services, which is going to be implemented over a 4-year period to allow for a more gradual adjustment for these affected practitioners. And again, we've listed those affected CPT codes there. The fifth change allows general supervision for behavioral health services furnished incident to physician or NPP services in RHCs and FQHCs. Lastly, it's worth mentioning that Medicare is going to cover and pay for intensive outpatient services, or IOP, in hospital outpatient departments, community mental health centers, RHCs, FQHCs, and opioid treatment centers. These services will be allowed when the physician determines that a patient needs a minimum of 9 hours of IOP services per week and must occur every other month at the minimum. So that ends it for me for behavioral health. I'm going to pass it back over to Valerie to wrap us up.
Thank you again for joining us today. We're glad we were able to share a bit more about this fee schedule. If you have any questions, we're happy to assist you and help you through navigating as these rules are continued to be refined and defined within the manuals and local coverage determinations and other guidance documents. So we welcome your questions, and as we move on to January 1 of 2024, look forward to the new year with you. So I'll turn it back over to Caitlin, and hope you all have a great day.
Well, thanks so much to our presenters, Valerie, Carine, Katie, and Miriam. Please remember to stay on the line once the webinar disconnects to complete a short survey. Later today, you will receive an email with their contact information and a recording of the webinar. Also, the slides and recordings for every episode of PYA's Healthcare Regulatory Roundup series are available on the Insights page of PYA's website, which is pyapc.com. While at our website, you may register for other PYA webinars and learn more about the full range of services offered by PYA. Please remember to stay on the line once the webinar disconnects to complete a short survey and post any questions you may have. On behalf of PYA, thank you so much for joining us, and we hope you have a great rest of your day.